See here. So we're good to go on that. And I'm going to introduce our presenter. So Dr. Daniel Gluckstein grew up in the city of Detroit and attended public schools there before college at University of Michigan. For his MD, he attended Washington University in St. Louis. Dr. Gluckstein has been working in the field of infectious diseases for several decades, including his current position as the medical director for infectious disease at Pomona Valley Hospital, where his major responsibilities include the infection control department and antibiotic stewardship program. Dr. Gluckstein's non-professional work experience during junior high through medical school included Detroit Free Press newspaper route, love that, janitor at a meat company, shipping terminal loading dock work, cafeteria short order cook, hospital orderly, and industrial microbiology media preparation. His avocational interests include home gardening, ice hockey, amateur paleontology, and mountain biking. As you can see, he's in the mountains this morning. Maybe just finishing up a ride. But please do join me in welcoming our presenter today, Dr. Daniel Gluckstein. Thank you so much for being with us. I'm going to turn it over to you.
Okay, good morning, everybody. I'm really glad to join you to talk about COVID-19. Just like all of us, we had our first case of COVID in early March of 2020, and it's been a huge challenge in the healthcare setting and certainly at the hospital and in infectious disease practice. So I want to share with you some of the things that we've learned and I think where we are now in the pandemic, and then looking ahead to the future and also throwing in some historical perspective. With all pandemics and a lot of crises in our lives at the time it's happening, it's hard to know where you are and where things are going and getting a perspective on where things are been. So I hope I can help you with that. Obviously, this is a huge topic and the literature on this has just swamped everything else in sort of medicine and a lot of scientific research. So I won't be able to address everything in my talk, but certainly if you have questions about particular areas I didn't address or you want some more detail, we'll cover it in the questions at the end, and I hope we have plenty of time for that. So let's get started. Just as an overview, I'll give you a little bit of a historical perspective on pandemics, go over some current COVID-19 data, particularly looking at cases, hospitalizations, deaths, speak a bit about the Delta variant, which has clearly been a lot of what's been going on the last few months, a little bit about testing, speak shortly about the disease itself and where we are with treatments for this. Talk some about prevention. We're all pretty much become experts in masks and distancing, but talk about that a little bit. Clearly, there's a lot of new developments in vaccines, and even yesterday, a substantially important article came out and already was on the news this morning. And I think as well, stepping back and looking with a longer lens at some of the societal issues that have been exposed by COVID. A lot of them we knew were there, but certainly COVID expanded the fractures that these can create, and then the opportunities coming out of COVID as we move forward in 2021 and certainly into 2022 and 23. So just to talk a little bit about pandemics, these are some photos of the 1918 influenza pandemic. This was an H1N1 flu at the early years of the 20th century. It had a huge impact at the time, and you can see in these pictures, people are wearing masks. We had hospitals and emergency hospitals built in all sorts of places like gymnasiums and warehouses. And a lot of this really happened with COVID. We've certainly had other pandemics in the 20th century. I started as my professional work in infectious disease right in 1981 when HIV/AIDS developed. It took us 4 years to discover the cause of AIDS. In perspective with COVID, from the Chinese officially recognizing the disease, it was 8 days until the entire sequence of the virus was published. Just a huge event. While we do have effective medicines for HIV and AIDS, and it's now a very treatable disease, we still don't have a vaccine. And comparatively with COVID, we already have several very effective vaccines. Moving into the 21st century, in 2002, most of you probably don't recall if you're younger, the SARS pandemic. That was a related coronavirus to COVID-19 that created a lot of panic, and a lot of the countries that did quite well with COVID dealt with SARS almost 20 years ago and used that experience to help their response to COVID to be more effective in preventing cases and deaths. In 2009, we had H1N1 influenza, which was a more serious strain of influenza than we had seen for a number of years. And this certainly impacted our care for patients at the hospital. At the time, in October of 2009, we were down to our last ventilator. And if somebody else had come in who needed a ventilator because of respiratory failure, we would have had to decide if we would take another patient off the ventilator. And then vaccinations started to kick in, and the disease virtually disappeared within just a month or two. And now we're dealing with COVID-19 that officially started in late 2019 in China and has spread worldwide over the last 2 years. So this gives us an idea, looking at infectious disease mortality in the United States. And when we looked from 1900 on, it was declining dramatically due to improvements in public health, particularly clean food and clean water, and increasingly vaccination, improving healthcare. And then right before 1920 and 1918, there's this huge spike in mortality. And this is population adjusted. That is unprecedented. And that was the 1918 influenza pandemic that was unusual in that it tended to kill not only like flu that we usually experience, either very young children or the elderly, but it killed healthy young people as well. So it had a very dramatic effect on mortality. It was relatively short, about 1.5 years, but with several waves. So a lot of parallels to COVID. And you can see long-term then, we reverted to sort of this gradual decline in infectious disease mortality. So by the late 50s and 60s, these were rare causes of death. And then at the tail end in the 1980s, the slight rise is almost all due to HIV and AIDS. So we learned a lot from this pandemic, but unfortunately, a lot of things we forgot. All the writers at the time recognized how unpredictable it was. There were several waves of disease. In general, they got worse with successive waves. And again, as I mentioned before, we had unusual situations that healthy people in the prime of life, in their late teens, 20s, and 30s, would be well one day and within 48 hours might be dead. There were dramatic differences in local policies in dealing with this. Some communities were very effective in instituting social distancing. And this photo is Gunnison, Colorado, where there were 1,300 people living there. They closed the schools, and basically people had food supplies at home and stayed home for most of the winter and had no cases of influenza during that time, whereas other areas had very large numbers of illness and deaths. Some areas continued to have parades right at the end of World War I that were super spreader events, whereas other cities and towns did not do this and had much better effect in low cases of influenza. So you can see a lot of these things that are really traditional public health measures, particularly with respiratory virus, were clearly delineated back over 100 years ago as being effective in dealing with a respiratory virus pandemic. But we've had to learn some of these lessons the hard way again with COVID-19. So I'll shift a bit and show you some data now with COVID-19. So this is daily cases of COVID-19 diagnosed per million population, and just showing the US and Canada over time. So you can see the US is in the brown. So we started to have cases in March of 2020, and most of this was the experience to some degree in Seattle, but more dramatically in terms of numbers on the East Coast, particularly New York area. But we had some cases here, and then a more dramatic spike of summer of 2020 that began really shortly after Memorial Day. And this was certainly a large burden here as well. And then beginning with this little bump here, that's really Halloween, we had a dramatic surge in cases, and a lot of this was now driven by the sort of British variant, as well as an LA variant that seemed to be somewhat more contagious than the earlier strains, and dramatically high numbers of cases per day by the winter of 2020 and into early 2021. And then a very rapid decline, and this correlates really with a lot of measures being put into place, and as well vaccination starting up, then continued gradual decline. We got to fairly low numbers by the middle of June, and it looked like COVID was going away. And then we entered the Delta wave, and I'll show you some more data on that, with dramatic increases just as we had really pulled away masking and social distancing requirements right in the middle of June. And so we're now on the downslope of that. And you can see Canada, that really is quite similar to the US in a lot of ways, had similar waves, but we tended to have, again, because these are population adjusted numbers, at least 3 to 4 to 5 times as many cases as Canada did. Now, here's the data, basically over the same time period on confirmed deaths from COVID. Now, we also know that COVID deaths aren't fully counted because there are clearly people who may die at home from heart attacks or strokes that may have been related to COVID in the last week or two before, but they were never diagnosed with COVID. But you can see the same sort of pattern in deaths playing out with waves, though clearly early on, when we weren't very experienced in taking care of people with COVID and preventive measures, there were lots more deaths per million people early on compared to later. But certainly our experience suggests that we haven't done as good a job at preventing deaths even compared to Canada. And right now we're still having about 1,600 deaths a day. So that's the equivalent of about 8 airplanes a day with 200 people on each plane crashing every day. So certainly this is still a dramatic influence on mortality. And this is the data for LA County. And you can see pretty much the same pattern, except we didn't have nearly as many cases early on in the spring of 2020, and certainly a fairly substantial wave in the summer of 2020. Our big burden of cases was certainly in the winter months, and you can see that dramatic rise. And then we actually got our baseline very low, pretty close to zero. And then Delta hit us beginning in late June, just as we were relaxing all the constraints on masking and social distancing, and had distributed quite a bit of vaccine. You can see compared to the winter outbreak, which again was mostly the British and LA variants, the slope isn't as steep, and that's probably due to a lot of the other things we're doing, and particularly vaccination, but it's still a fairly substantial rise in cases. And there's a few little bumps sometimes because of interruptions in testing for weekends or holidays, and sometimes also pushed by the increased new cases associated with social gatherings with weekends and holidays. Just to show you in a little more detail, again, you can see some of that. Here's 4th of July last summer. Halloween seemed to push a little bump in new diagnoses. And then you can start to see this is Thanksgiving right here. And then Christmas, New Year's, we started vaccination near the end of December. And then that has continued through to the present with this dramatic decline, almost a mirror image of the rise. And then here's where we stopped our masking and social distancing for a little bit, and then we had to put them back on within a month later or so. So now we're seeing a gradual decline as we head towards the end of October. And where this line goes is going to be dependent on what we do with vaccinations and other measures going forward. So we'll talk some more about that. One of the dramatic things we've learned with COVID is that there are really very large inequities in the social determinants of our health and our society. And these are related to risks of exposure at work and at home, access to care, access to vaccine, and historically based distrust of the healthcare system and communication problems with the healthcare system. So this shows that ongoing since the beginning of the pandemic, American Indian and Alaska Natives have had the highest case rates and hospitalization rates. Black African Americans as well have higher rates, Hispanic Latinos as well compared to whites, and Asian Pacific Islanders generally have the lowest rates ongoing. So this has certainly been a consistent trend throughout the COVID pandemic, and we see this with a lot of other diseases, and this has been known for a number of decades. As well, when you look at not just cases, but deaths, so this compares in red the number of deaths proportionally to the amount of that group within the population. So non-Hispanic whites generally have fewer deaths than their proportion in the population, while Hispanics have increased death compared to their proportion. That's also true for non-Hispanic Blacks, flips again for non-Hispanic Asians. So again, all this has exposed the inequities that exist in our society in dealing with this disease and the mortality. So I'll switch a little bit and talk about the variants. I don't want to get too deep into the biology of this, but the SARS-CoV-2 virus in this diagram has these red spikes that are the spike protein that is the main element that interacts with our immune system and the target of most of the vaccines. It binds to this ACE2 receptor on cells, mostly in the respiratory or GI tract, but throughout our bodies to then infect the cells and cause disease. If there are small variations in the amino acids that make up the spike protein, the shape can change slightly and somewhat change its properties, interacting with both the ACE2 receptor and potentially antibodies to protect us from getting sick from the disease. So that's the concept of what happens with the variants. There are certainly other things that can happen, but we won't discuss that in too much detail. Here's the bad news about the Delta variant. And this graph goes back to May of 2021. And you can see in the light orange here, this is sort of the B117 or British variant. The slightly darker orange is the P1 or Brazilian variant. The purple magenta is our sort of homegrown LA variant. And you can see that mostly we were dealing with the British variant, and this has been true going back to really the previous winter surge. And some of these others were competing with each other. In the medium orange here was the Delta variant. It was a relatively small percent, but then you can see in these 2-week segments very quickly it was able to completely obliterate all of these other variants and become the dominant variant. So by really the middle of July, it's already accounting for more than 80%. And now for the last several months, it's basically almost 100% of COVID. And this is for the Western region of the United States, including California. But dramatically as well, this is really true for the entire United States and most of the world. So it tells us that the Delta variant has dramatic ability to outcompete the other variants to cause cases, hospitalizations, and deaths. So this is really, well, it's not a different virus. It certainly has changed the game from where we were in late May and in the middle of June. So that's why we're having so much difficulty now with COVID and have had to go back to wearing masks and really emphasize social distancing and vaccines. To show you a little more about the Delta variant, this was a study out of England looking at household and non-household spread of the Alpha or British variant in the pink and then the Delta variant in the purple. And you can see comparing non-household in the dashed lines and household in the solid lines. It's about twice as infectious. So within a household, about 10 to 15% of people living in that house would be infected from one person, whereas with the British variant or Alpha, that number would only be about 6 or 7%. And then outside of households, again, it's about twice as infectious. So that certainly changed the game in the ability of this virus to spread in the population. So to summarize what we know about Delta, it's clearly at least 2 to 3 times more infectious than prior strains of COVID, and even at least 50% more infectious than the sort of Alpha or British variant. People with Delta infection and even people who have been vaccinated will, if they become infected, have at least 1,000 times more virus in their nose and throat with the infection. So there's more of it that probably explains its ability to spread as well. However, we still see almost all the hospitalizations are in unvaccinated persons. This has been declining slightly as time goes by, since most of us have been vaccinated, that we do lose some vaccine efficacy. So prior to Delta, vaccines prevented about 8 to 9 out of 10 asymptomatic infections. That's dropped to 6 or 7. For people becoming symptomatic with Delta, now about 7 to 8 out of 10 would still have protection versus that was more than 90% earlier. We now know that clearly people who have been vaccinated or previously infected can be reinfected with Delta and can transmit it to others people. They seem to be, after the first few days, less infectious, but this is certainly a problem. The good news out of this bad news is that the vaccine still prevents most Delta infections in vaccinated people. It prevents about 85 to 90% of hospitalizations and even over 90% and close to 95% of deaths with Delta. So while it doesn't do as good a job with vaccination and preventing infections, it still does a good job in preventing serious illness or death. Talk a little bit about the testing. I think most of you have heard of the PCR or polymerase chain reaction test that looks for the RNA material of the virus, usually nasopharyngeal secretions. Alternatively, increasingly, and really since earlier this year, we've had access to some degree to what are called antigen tests that look for some of the proteins of the virus, usually again in nasal secretions. So they're a little bit different in that the PCR test will detect a current infection by detecting the RNA, but because it's extremely sensitive to small amounts of RNA, it can't really tell you if you're infectious compared to the antigen test isn't as sensitive, but if you're positive, you're very likely to be recently infected and contagious. Unfortunately, the PCR tests in general have to be done in a hospital or very experienced laboratory setting, whereas a lot of these antigen tests are now being produced so that they can be done at home with minimal expertise. It's probably about as difficult as making cookies or something like that. They tend to turn around quicker than the PCR tests. They're less expensive. However, they may occasionally give false negatives, but they can be done at home. And as well, the current presidential administration has just invested a large amount of money in producing more of these tests. And ideally, we will start to see more cost drops, and ideally the ability of us to have some of these at home to test on a more regular basis. And certainly I know a lot of schools and universities and other businesses are using them periodically to look for people who may have asymptomatic disease, and certainly to test people who are symptomatic so they don't expose others. Again, just on the timing of these two tests, the good thing of the PCR test is if you have virus, it will usually find it. And it usually is a few days before you have symptoms, and then the red line, it goes up fairly quickly. But the problem with it is you could have been contagious a week ago or a month ago, and you're still positive for potentially several months out. The antigen test, while it misses some cases during the contagious period, it's a pretty good marker that you probably are contagious and recently infected. So you might have a better idea that certainly you need to quarantine and where you may have acquired infection. So that's how we have to think about using these tests. Talk a little bit about the diseases. I think probably most of you have heard early on in sort of the stage 1 of COVID-19, it's really a viral growth phase where you're starting to have initially no symptoms, and then usually some combination of loss of taste or smell, potentially runny nose, sore throat, fatigue, muscle ache, headache, and then sometimes a bit of a dry cough. These are the common symptoms, and don't necessarily mean you're going to get very sick from it. However, in the people that then progress to more serious illness and may need to be in the hospital, it tends to then progress to an infection of the lung, the pneumonia, where they start to have more shortness of breath, changes in their oxygen levels, abnormal x-rays or other tests. And then as time goes by, and this is usually somewhere around 7 to 10 days after infection, then the immune system may kick in response to the virus in the lungs and other parts of the body, and you get this vigorous inflammation with more severe fevers, more severe lung damage, low blood pressure, potentially kidney problems, liver problems. And these are the people that end up very sick in the hospital and often in the ICU or breathing machines, or are at very high risk for death. We do have some treatments, however, and probably the best one early on are these monoclonal antibodies that are increasingly available. They're quite expensive, but generally available, but have to be given ideally early on in this viral phase. So particularly if you know somebody or you yourself are at higher risk for serious disease because of age or underlying illness, these are certainly worth trying to access through your healthcare provider. We give them at Pomona Valley quite frequently, but the key is to get tested, get diagnosed, and then get plugged in before you're into a week to 10 days into illness where their efficacy decreases. If you're sick enough to be in the hospital, particularly because of pneumonia and low oxygen levels, we routinely give people remdesivir, a steroid medicine called dexamethasone, oxygen, and then there are some other anti-inflammatory medicines we would give here. But the real trick is to never even get sick in the first place, so you don't have to go through the illness and risk of complications of the viral infection. Just to emphasize a little bit, I'm not going to show you a lot of detail of this, but we now have a massive amount of information both in the US and worldwide, that masks and social distancing, just like they worked for flu over 100 years ago, they also work for COVID. And whereas last year, most schools and universities were closed to in-person learning, we now know we can do this quite safely. The biggest risk is really the risk of COVID in the community where the institution is located. So, but lots of school systems have now shown with consistent use of masks, smaller groups of students, some distancing. If somebody's exposed or sick, they don't come to school, we can have very low numbers of students. So in this group over 13 weeks, only 7 students were infected, none of the staff. And again, most of it was related to home or community exposure rather than in schools. But again, like anything, you have to do these things consistently in order to be effective. The bad side, as an example, was this fairly well publicized outbreak in a school in Marin County, an elementary school, where an unvaccinated teacher took off their masks to read some stories to the students over a couple of days, and 12 out of the 24 kids in the class, none of them vaccinated because they were under age 12, became infected. So it tells you with a little bit of carelessness, this virus is quite contagious, and they were using open doors and open windows at the time because this was still in the late summer, early fall. So it emphasizes the need to be really consistent, particularly when we're indoors with other people. So the biggest advance that we've had in COVID, more than medications to treat the disease, is in vaccines to prevent the disease. So this summarizes the 3 vaccines that are available in the US at present. 2 of them are mRNA vaccines, the Pfizer, BioNTech, and Moderna, and the J&J or Janssen is an adenovirus vector vaccine. They had been emergently approved for 2 doses for the RNA vaccines, 1 dose for the Janssen. And just recently, over the last month or 2, Pfizer was approved for use for people with immune system disease because they don't get good response with this 2 doses to get a 3rd doses. And then just recently for people with other higher risk conditions by age or other illnesses to get a booster after 6 months. In the next few days to weeks, we will probably be hearing a lot more about Moderna. They're presenting data to the FDA, and advisory committees will be ruling on this probably even potentially by the end of this week. This may also occur for Janssen, though they're a little farther behind. We know both for preventing cases and certainly hospitalization and deaths, the mRNA vaccines have quite high efficacy and moderate efficacy for the Janssen. As we've given it to millions and millions of people, we now know there are some rare adverse events beyond the typical arm soreness, mild fever, fatigue, of an inflammation of the heart that's usually clinically very mild, of myocarditis in the RNA vaccines, and more worrisome, but also quite rare, and more so in younger women, blood clots in the brain and other blood clots that can be fatal. So we've learned something from our surveillance systems that we didn't know from the initial clinical trials. But overall, these vaccines are clearly safe and effective for most of us. So again, to summarize, particularly as we go into the Delta wave, the question is, how good are these vaccines? And we've known for Alpha, they were about 94% for the RNA Pfizer vaccine, some decrease for the Delta. But for hospitalization, they still do quite good. England and Israel have very robust studies going on where people are sampled regularly to look for asymptomatic infection and good data tracking of people who become positive, and then if they have to be hospitalized as well. Again, the vaccines continue to do quite well, even in the Delta area, but they have had some loss in efficacy. Looking as well at data in the US, this shows the case rate for new COVID cases per 100,000 population in different states in the US. And you can see as the vaccination rate goes up in the population, the case rate goes down, providing very strong evidence that on a population level, that vaccination is very effective in reducing cases. And obviously, if you reduce cases, you reduce hospitalization and deaths. This is also more recent data out of another surveillance system in the United States, and breaking down in blue unvaccinated people. And this is people who have had no vaccines compared to people who have completed a vaccine series, either with 2 mRNA or 1 Johnson & Johnson. And you can see in younger people that, and these are hospitalizations, not just cases. So the vaccine is about 24 times less hospitalizations than if you are unvaccinated. 50 to 64-year-olds, some decline in vaccine efficacy. And you can see in the gray bar is sort of the Delta era of the last few months, that the green line doesn't go up much, where you start to see a bump up in the younger people and middle-aged people, and in over 65, a more dramatic increase and a slight increase in the vaccinated, likely reflecting slight efficacy decline with time and in the older age group. But again, still dramatic protection from hospitalization across a wide spectrum of ages in people who are vaccinated compared to non-vaccinated. So another demonstration of real-world efficacy. This is sort of my little summary about what happens in Delta. If you're vaccinated, you have a small risk, somewhere on the order of 5% of being hospitalized, and well under 1% for dying. You have somewhere around a 10 to 20% for moderate to mild disease, where you'll be sick at home. Probably 15, 20% or so for asymptomatic infection, but about 65% of us won't get infected. The myocarditis risk is this little line down here that's somewhere on the order of 1 in several thousand. But if you don't get vaccinated and you get infected, you have a substantial risk of death of somewhere on the order of several percent, about a 20% risk of hospitalization, very substantial, about 50% risk of being ill at home, and about a 30% risk of asymptomatic infection. And actually your risk of myocarditis from the infection itself is somewhere on the order of at least 10 or more greater than from the vaccine. So you sort of lose on every measure. And certainly I didn't include in here, but we're now certainly learning that a chronic illness post-COVID called long COVID occurs in certainly at least 15% of people with symptomatic infection, and may well be as high as 40% in older people, and seems to be also higher risk in women as well. So there's lots of reasons to say the vaccine is still better for you than risking getting infected. So again, despite Delta, we can see the vaccine continues to prevent infections and save lives. We've seen some loss in efficacy for preventing infection and symptomatic diseases. And most of the data is because that's what we've used most, is the RNA vaccines. We don't have quite as much data for the Johnson & Johnson, but we're now seeing clearly that it's probably not as potent against the Delta variant, and with time losing some of that efficacy. So vaccination is really our #1 strategy to reduce cases, serious illness, and death. And by doing that, we also reduce new variants emerging in our population. Uh, Talk a little bit about the boosters. It's a little confusing because the first recommendation from the FDA and CDC was for people who have serious immune system problems. So these are people who, even despite getting vaccinated, their immune system cannot respond to 1 or 2 doses of vaccine as effectively as people without these illnesses. So mostly it's people with cancers or cancer treatment, organ transplants, certain genetic severe immunodeficiencies, advanced HIV infection with weakened immune system, taking medications, oftentimes for autoimmune disease, that have immunosuppression from the medications. And certainly people who have any of these illnesses or other concerns should talk to their healthcare provider about this. But we've been doing this now for quite a while, the last several months, to try and give people more protection with the 3rd dose. And then the new thing, again, so far just for the Pfizer vaccine, but likely the Moderna will also be approved for a booster in the near future, and possibly even the Johnson & Johnson. But the groups that are recommended, if it's been more than 6 months since your prior vaccination series, age at least 65, any sort of chronic long-term care residents because of health conditions, people with cancer, chronic kidney disease, chronic lung disease or smoking, dementia, big group with diabetes should get the booster dose, Down syndrome, anybody with substantial heart disease or liver disease, being overweight with a BMI of at least 25 is a high risk group. Pregnancy is clearly a high risk group. And in some areas, 1 in 5 people in the hospital with COVID are now pregnant women. Chronic blood diseases like sickle cell or thalassemia, chronic neurologic diseases like stroke and substance use disorder. As well, importantly, addressing some of the inequities and exposure to COVID, people who are frequently exposed to COVID. So in addition to healthcare workers, this would be first responders, educational staff, food, agricultural, grocery workers, manufacturers working with multiple other people with face-to-face contact, correction workers, lots of public transit workers, postal services. And you can see this can tend to be a fairly large group of people who have to go to work in person with other people on a daily basis as part of their lives. So where are we with vaccinations? So this is data from LA County that the LA Times actually publishes regularly. So we're just approaching about 70% of people having at least 1 vaccine and over 60% with 2 vaccines. You can see the separation is fairly stable. So it looks like most of the people who get 1 go on to get 2. However, over on the right, you can see compared to our dramatic increase in doses per day, we've had a decline, but have plateaued for the last several months. So ideally, we want to really get this to go up again so we can get to high levels of immunity and be like Vermont, where we see dramatic decreases in our cases moving forward. As we mentioned before, there are clearly inequities by race and ethnicity and who gets vaccinated. So you can see among our Black African-American population in LA County, just about half have had 1 vaccine. Similarly, but slightly better numbers for Latino population, white population, higher numbers. So, but still about a third are not vaccinated at all. Asian Pacific Islanders and American Indian Alaska Natives have the highest rates of vaccination. But again, there are a lot of different inequities and issues that are contributing to this. So we need to continue to reach out to groups to address their concerns with vaccination to see if we can get higher vaccination rates across our population. As well by age, we're really doing quite well that in all groups, at least 60% of people have had two vaccines, and obviously children under 12 aren't eligible yet, though that may certainly happen within the next month or so. But we still have room to go. And surprisingly, despite being the highest risk group overall for serious illness or death, people 65 and above are less than the 50 to 64 group. So we still need to try and reach that group a little better. This is a study that just came out in a preprint yesterday. And again, as I mentioned earlier, is already on the news. That using booster doses with potentially a different type of vaccine can be done reasonably safely. However, a lot of caveats so far. This was only about 450 people, so it's not 100,000, and it's just measuring antibody responses, which is probably a good measure of protection, but it doesn't reflect preventing infections, hospitalizations, or deaths as a proven outcome. But the bottom line is the largest increases in antibodies, particularly with time, were with the mRNA vaccine compared to the adenovirus Janssen vaccine. There was no difference in adverse events. So if you had initially gotten the Johnson & Johnson, it looks like you could certainly get a bump in your antibodies more if you got a booster with the Moderna or Pfizer. There was a hint maybe the Moderna is a little more potent. It contains actually 3 times plus as much RNA as the Pfizer with the initial dose, and still more, but not quite as big an increase with the booster dose. But you can see across all these groups, if you get a third dose, and particularly if it's a mRNA vaccine, you get better levels. So where this is going to go with the FDA and CDC, we don't know yet, but quite possibly we will in the near future be told that you can certainly seek out an mRNA vaccine for your booster, particularly if you had gotten a Johnson & Johnson as your only vaccine so far. So some top line messages I want to give you. Again, number one, it's pretty clear that getting vaccinated is the best way to prevent severe illness, hospitalization, and death. It also reduces spread in the community and population level reduces cases. And this is clearly more important with Delta, where we're seeing the more rapid spread and increase in cases, hospitalizations, and death, particularly in unvaccinated people. Again, Delta is somewhat different compared to our experience earlier on. And even if you had been infected a year ago with a prior strain, you might not have as much protection as you would get with at least one vaccine dose on top of your prior infection, and certainly getting a full vaccine series. Again, almost all hospitalizations and deaths continue to be among the unvaccinated. Again, because almost the entire country has still substantial community transmission, though we've made a lot of progress here, continuing to wear masks in indoor public settings is really important, even if you're vaccinated now with Delta, and to have community leaders continue to emphasize this, and particularly in sort of group settings like schools, universities. And we certainly have been doing this at the hospital all along, wearing masks at all our meetings, all our interactions with other people, regardless of vaccination status. And ideally, we will be able to extend the benefits of vaccination to younger children in the near future. I want to say a few things about some of the other things we've learned about COVID. Clearly, it's aggravated some of our societal problems, the social determinants of health by education, healthcare, where we live, who we interact with at work and socially, and our financial ability to deal with our lives. It's aggravated racial and ethnic inequities, educational inequities, huge mental health impact. And as the pandemic drags on, this is certainly a bigger burden on all of us, whether you're students, healthcare workers, anything we do. It's clearly emphasized that our nursing home system has lots of problems in protecting a very vulnerable population. It's clear that we have to invest more seriously in public health as a long-term preventive and safety net when pandemics and other crises emerge, whether it's COVID or HIV or tuberculosis or lead in our water systems. We've got a lot of dysfunction in our healthcare system that contributes to bad outcomes. Clearly, increasingly, we know more and more about misinformation and the damage it does by spreading information that is inaccurate and can lead to illness, death, and other harms. We've clearly seen politicization of science into my team, your team problems. And I think more than anything else is that leadership really matters on an everyday basis, and even more so when we're in a crisis. So where we're going to go for the next several months and the next several years really depends on what we did the last 2 years, and even more importantly, what we do from this day forward. We're clearly seeing this nice drop in the US. We should have never gotten this high. And clearly Canada has been doing some things better than us, though they clearly have had some of the same problems that we do. So I think it clearly, as we move forward, particularly 2021 and into 2022, we're going to have ongoing developments in vaccination that will likely give us better protection, and what vaccines and when. We're going to continue, at least for a while, to push that curve down. We're going to need to continue to mask and social distance clearly, so we don't have a turnaround and bump in cases, hospitalizations, and death as we move into the winter season. Certainly as well, we should all get our influenza vaccines, because if you get sick at some point in the next 6 months, you're going to need to get a COVID test, and it may be influenza. And if you can prevent that, and also not burden the healthcare system with influenza cases, we're all going to be better moving forward. We will probably have some more developments in medication. There's a promising drug that might be able to be used on the outpatient side that actually looks pretty good at preventing COVID, but not as good as vaccine. And then the other huge challenge is to prevent and control COVID, not just in the US and high income countries, but worldwide, so we don't have continued waves of variants moving forward. Longer term, looking ahead more than a year and 2 years, it's pretty clear COVID is not going away. It's going to become probably a respiratory illness, more like a cold. There are currently 4 other coronaviruses that we get every few years that cause a common cold type illness. But it will also probably become an ongoing vaccine that we get at least every few years, and as part of routine childhood vaccination. This graph here shows a number of models that have been fairly accurate in predicting where COVID is going based on what we're doing and trends in the disease itself. And you can see in different models, there's a really large variety of outcomes of where we go. And we ideally want to get this number as close to 0 as possible. So as the numbers get lower, we can start to relax restrictions. But again, only if more and more of us are protected through vaccination. So that really determines where we go in the next several months. And certainly the expectations are, if we stay on this track, by spring of 2022, we should be substantially close to where we were back in June of 2020, before 2021, before Delta hit. So I think, just to end this on a hopeful note, while COVID has really caught us with a lot of problems across the society and impacted all of our lives, it does create opportunities. And for all of you that are students and teachers and leaders in the community, to make your impact on all these areas so we have a better society moving forward. by tackling these issues as we deal with COVID. With that, I'll end and be glad to take questions.
Thank you so much, Dr. Gluckstein. This has been wonderful. Obviously, all of us, this touches all of our lives and how we live day to day. Many of us have lost people to COVID. So I really appreciate you taking the time. I also appreciate your emphasis on, enforcement and proper mask wearing and all of that with the Marin school unfortunate example, because I think sometimes when we start getting used to wearing masks and that being part of daily life, it can become more theater than it is, seriously taken precautions. So love the reminder to wear masks properly, and that, policy is kind of no good without enforcement.
Right. Yeah. And ideally, it has to be internal enforcement. I sometimes still leave my mask in the car when I go into the office or hospital, and I have to go back and grab it. But it's long term, it's going to make a difference. And as we get our community numbers lower and lower and more of us vaccinated, at some point we should be able to take them off and keep them off, except in extremely high risk settings. And certainly, even if myself as an individual isn't at high risk because I'm vaccinated and don't have underlying conditions, it's who I expose that may then expose somebody else who cannot deal with the virus effectively and gets very sick or dies. So we're certainly all interconnected, but it's hard to see that it may be somebody 2 or 3 weeks or a month later that bears the price of our carelessness in doing those things that we all have to do.
Yeah, absolutely. I think that lesson that you just said, that we're all connected, has been a really profound one for us in the United States during this whole pandemic. We probably have time for one question because we're at the end of our time here. I haven't seen any come through on the chat, but if you have one, please do put it in, or you can unmute yourself, and I'll leave, a few seconds here for anyone to speak up before we thank our presenter one last time. Oh, good question. So someone just received the COVID booster on Monday and is wondering when it's safe to get the flu shot.
Okay, good. Yeah, this is a great question. Early on, when the vaccines were first being distributed, it was recommended that you separate the shots by at least 2 weeks, the COVID vaccine from any other vaccine. There's been no signal of any increased risk of side effects. That was mainly because of a concern that if you had something happen, it would be hard to know which vaccine caused it. So you can get them at the same time. So you don't need to wait. I got mine, I got my third COVID about 2 weeks ago and got my flu shot a week ago. And so you can go with it that way.
Great, that's wonderful.
Okay, yeah, I see a question about what about patients who are strongly anti-vaccine? You have to meet them where they are. This is a really difficult thing to do because we all just want to lecture, and you have to sort of try and take some time to sit down and find out what their concerns are. Certainly, if it's based on misinformation, you want to state what is the misinformation and what is the proper factual information about it. Sometimes it's based on mistrust or distrust of the messenger or the system that's trying to give the vaccine. So then you have to ideally address that, or ideally get a more trusted messenger. There's been a lot of progress in some areas about certainly getting community leaders outside of the healthcare system oftentimes, or certainly encourage them to speak to a healthcare provider that they trust, and make it more of a discussion and process rather than trying to fix it in a 2-minute conversation because it may be more of a process as well. That's sort of an entire lecture, and social psychologists are really looking at this carefully. But sometimes the concerns are just practical issues that if I have to take off work to go get a vaccine and I don't have time to do that, I'm going to continue to put it off. And addressing some of those issues by availability at work, at a neighborhood pharmacy, offering to provide childcare so somebody doesn't have to deal with that as a barrier.
Yeah.
Okay.
If you have time for this last one, we have one last one that Eileen is asking about. Do we know the long-term effects of any of the vaccines? Could it cause cancer in the future or other diseases?
Well, we can never disprove a no in the future, but there has been no evidence of this with vaccines in general. And in fact, almost all side effects of vaccines show up usually within 2 weeks to at most 4 to 6 weeks after vaccination. The mRNA vaccines do not change your DNA, so they are not mutagenic in that sense. We haven't seen other underlying diseases except rarely. And again, because it's sort of the trade-off is you're at risk of COVID, and we clearly do know COVID can cause a lot of bad things short-term and bad things longer-term. And we don't know as well that COVID doesn't cause cancer, but certainly the more sick you are, it deteriorates your other health and other conditions. I mentioned we have seen myocarditis as a really mild disease that clears up generally within several days to a week, and much less in people who are vaccinated than the risk of myocarditis as a more serious effect of that severe COVID with severe inflammation. And again, we have several vaccines that actually prevent cancer, including the HPV vaccine and the hepatitis B vaccine are really dramatically effective in preventing cancers.
Great point. Well, I want to be respectful of your time. Thank you so much. And thanks for taking a few minutes extra here. Really appreciate it. Hopefully over time, we continue to have these kinds of presentations as COVID changes and evolves. And I appreciate everyone in the audience for taking the time. And of course, you, Dr. Gluckstein, for giving generously of your time and your expertise with us today.
Hey, could I address this one question? Because I think it's important.
Please, if you have the time.
There was a question about natural immunity. So clearly, when people get infected with COVID, they do generate immunity to COVID, more so to the strain they were infected with. Just like information on vaccine and how long the immunity lasts and how robust it is, not only for the same strain, but potentially different strains, we don't quite know. There are studies looking at this, and there are studies now looking at people who have had prior infection. And it's clear the less severely ill you are most of the time, the lower your antibody levels are from the infection, and the more likely they are to decline with time. So the sicker you are, unfortunately, you take a risk of having serious illness. But then if you get through that, you may be protected from reinfection for somewhere on the order of something like 6 months. We don't know yet as much about variants. We also know if you then get even just one vaccine, you tend to get broader immunity to different variants, and you get a bump in your immunity. So if somebody was reluctant to get 2 vaccines, it wouldn't be unreasonable, particularly if you're out 6 months or so, and particularly if you were infected a year ago, to say you should probably get at least an mRNA vaccine and see where things go. We don't yet have relatively easily available clinical tests to measure neutralizing antibodies, and we don't have clinical tests to measure also what's probably important is T-cell immunity and other elements of the immune system. But with time, we're certainly seeing people who had prior infection do get reinfected and do get sick. So I would still recommend at least one vaccine with an mRNA vaccine. But we shouldn't negate that there is no protection from prior infection. That is certainly false in general.
Thank you for answering that. Yeah, I've heard people say antibodies are antibodies. And so it's clearly a more nuanced and complex topic that we're working.
Yeah. I mean, the world is always more complex than we think it is, but and COVID has certainly shown that as well.
Absolutely. Well, thank you so much again, and everyone for sticking around. I really deeply appreciate it. I'm going to stop recording now, and I will hang around in case anyone has any kind of technical questions or how to follow up.
Okay, thank you again.